Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled Key Viral Hepatitis Studies Influencing My Practice Following EASL 2022. During this podcast, Dr. Stefan Zeuzem, Professor of Medicine and Chief in the Department of Medicine at J.W. Goethe University Hospital in Frankfurt, Germany, discusses new viral hepatitis data, including studies related to hepatitis B, hepatitis delta, and hepatitis C, presented at EASL 2022. For more information about Dr. Zeuzem and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Zeuzem has to say about new viral hepatitis data from EASL 2022.
We will cover some investigational agents for hepatitis B. We will cover the HBV cure data from the Everest Project in China. I will show you the most recent data of bulevirtide in delta hepatitis. And last but not least, we will go into treatment failures in hepatitis C and the options for retreatment. Currently, we have many agents in phase 2 development for chronic hepatitis B. There are novel compounds and mechanisms which are now more or less restricted to the following drug classes. We have antisense oligonucleotide. We have so-called ASPINs, which are active site polymerase inhibitor nucleotides. We have, for quite a long time, these capsid assembly modulators. We have the GalNAc RNA interference molecules. We have PDL1 antibodies, which are checkpoint inhibitors, and we have small interfering RNAs. So you can really see that genetic treatment is really making its pathway into the treatment of chronic hepatitis B. Here on this slide, I'll show you the REEF2 data, which is a combination study in e-antigen negative hepatitis B infected patients. And these patients were either treated with J&J 3989, which is an siRNA, and the CAM inhibitor called J&J 6379. And this was a randomized double-blind placebo-controlled phase 2b study in virologically suppressed patients who are all e-antigen negative and on the treatment with a nuke. The treatment of all the drugs was stopped after 48 weeks, and the primary endpoint was 24 weeks thereafter, the loss of HBs antigen and the unnecessity to restart nucleic acid therapy. So unfortunately, none of the patients in either study arm achieved the primary endpoint without restarting nuke therapy, but the overall data are still quite interesting. You see these data in the table, and if you see the proportion of patients who achieved HBs antigen levels below 100, you see that around about 70% achieved not only at the end of therapy, but also at follow-up week 24, the decline of HBs antigen to below 100. And this is substantially more than in the placebo plus nuke group. And also the patients in the follow-up group actually in the majority remained quite stable or actually showed even further decrease of the HBs antigen, overall roughly 60%. Additional siRNA efficacy data showed that the compound with or without the CAM reduced other viral markers, and that another siRNA, the VIR-2218, resulted similarly in another study in reductions in HBs antigen with 6 doses versus 2 doses. The safety of the compound was considerably good. You see actually only one significant severe adverse event case which was recently already published in full. That was a patient who developed in the off-treatment follow-up phase a significant flare, and in the end actually required a liver transplantation. But he survived, and this was actually in the arm which was treated with placebo and the nuke. But as you know, all treatment was stopped, and it occurred in the only nuke treatment arm. And this led to a redefinement of the retreatment criteria in the study, which is now defined with these compounds that you have to immediately start retreatment independent of ALT level when the HBV DNA level go beyond 100,000 IUs per ml. The interesting part really of this study was that a large majority of patients did not really require retreatment. So to take the significant points home, that the treatment with the two compounds, the siRNA and the CAM inhibitor plus nuke, significantly reduced HBs antigen level. No patients showed seroconversion or seroclearance, but the majority of patients actually did not require retreatment or reinitiation of nuke therapy. So it may be chance really to get patients off any kind of treatment, but of course those patients still require substantial surveillance. We only have 24-week data yet after stopping the treatment, and we of course need longer follow-up periods. Retreatment criteria should be carefully evaluated and should probably be strictly applied in the post-finite treatment period. And there are other siRNA molecules in development which are also demonstrating substantial reduction in HBs antigen. The question, however, for all these compounds is whether this reduction can be maintained and patients can remain off treatment due to low viral load and normalized aminotransferase. Another drug is the bulevirtide, which is oligonucleotide inhibiting also S expression, and the bulevirtide was tested in a large phase 2b randomized trial, either on patients, as you see in the upper panel, on stable nuke therapy, or in patients who were not currently on a nuke therapy. And these patients were randomized into 4 different arms, of which most important, the upper arm must be considered. This is the bulevirtide arm at 300 milligrams over a 24-week treatment period. The current analysis looked at the rates of HBs antigen below the lower limit of quantification and HBV DNA at a lower level of quantification at the end of the bulevirtide therapy. And if you see here and just focus again on the arm 1 in the 2 tables, which is the most left panel, with 68 and 70 patients respectively. And you see here that roughly in all these arms, 1/3 of the patients achieved actually a loss or an undetectable HBs antigen level, and also an HBV DNA below the lower limit of quantification. And most interesting data have been presented that this loss and negative HBV DNA seems to be maintained in the off-treatment period. And this is, of course, of high relevance and needs to be seen in further follow-up. The safety of this combination was generally good. Only a few patients had actually AEs leading to treatment discontinuation in a rate of 0 to 4%. It's only arm 3 where 7% of the patients had to stop therapy. Overall, it's probably further declining with more experience with this treatment. The SAEs, which were considered related to the study treatment, were extremely low, and the most important and most frequent side effects were injection site reactions, and the majority of laboratory changes had actually no correlation with the clinical severity. So taking the following points home, that approximately 1/3 of patients, regardless of nuke treatment, achieved an HBs antigen and an HBV DNA below detection at the end of the 24-week treatment with bepirovirsen, and there were better treatment responses in those with low HBs antigen at baseline and an E antigen negative status. Overall, this compound was safe and well tolerated, but now the response durability needs to be assessed in patients off treatment. Another compound which was explored is actually an old compound. You may remember clevidine. That is a compound which is non-competitive, a non-chain determining inhibitor of the HBV polymerase, which in the initial trial had severe side effects in the muscle, and therefore the development of clevidine was discontinued. Now, with new pharmacokinetic developments, this compound, which is now called ATI 2173, can be specifically delivered to the liver, and also only exploiting the antiviral efficacy in the liver, is not going to be delivered to the muscle, and therefore without the previous side effect the compound had with a different pharmacokinetic preparation. We had seen data in 2 cohorts where patients either received the clevidine prodrug at a 25 milligrams QD dose plus tenofovir, or at the 50 milligram QD dose plus tenofovir, and these were compared to tenofovir placebo-treated patients. The data showed that virologic suppression maintained off treatment in patients treated with ATI 2173. Virologic rebound at week 16 occurred in 100% of patients who were treated only with tenofovir, while the rebound was only 44% in patients treated with the clevidine prodrug plus tenofovir. Tenofovir was restarted at week 20 in 100% of patients in the TDF arm, and only in 1 out of 5 patients, 19%, in the arm where patients received the ATI 2173. So 80% actually remained off any treatment. There were no off-treatment ALT flares observed in the treatment of patients with ATI, and overall the antiviral efficacy was clearly more profound with a combination with clevidine plus tenofovir. So very interesting data, but the take-home points here again, combination ATI plus TDF leads to better outcomes at 24 weeks off treatment. So it shows really prolonged HBV DNA suppression, longer time to viral rebound, absence of ALT flares. But again, here, longer follow-up is required to see whether long-term benefits of patients are seen with this restart of clevidine with a clever new pharmacokinetic preparation. And last, in the hepatitis B field, I like to show you the data from China, which is a huge study with add-on or switch of patients who were on nuke therapy for at least a year with the add-on or switch to pegylated interferon alpha. And the question was here whether we are going to see higher rates of S antigen loss seroconversion in HBe antigen negative patients. The current analysis, which was shown, showed patients who completed 48 weeks of therapy, and the per protocol population was almost 4,000 patients. Study numbers, patient numbers, we probably could never achieve in Western countries. The per protocol analysis of those almost 4,000 patients showed an HbS antigen loss rate in week 12 of therapy of roughly 10%, which was almost doubled at week 24, and at week 48 achieved 33%. So an additional 1,006 patients achieved HbS antigen levels below 100, but not achieved HbS antigen loss. But again, a third lost HbS antigen. And interestingly, if you would ask US or European physicians, it would be a little bit surprising that the use of interferon was not causing any adverse events. At least the investigators did not report any severe adverse events. And that is actually also our previous experience with pegylated interferon. It's actually better tolerated in hepatitis B patients than in patients who were previously treated for hepatitis C with this compound. Predictors of the functional cure at week 48 was a lower HbS antigen level at baseline and at week 24. So very similar to all other drugs, the lower HbS antigen at baseline and during treatment predicts the chances of functional cure defined as loss of HbS antigen or seroconversion. There was also a higher rate of functional cures in patients who had an ALT elevation at week 12. So taken together, additional PEG interferon alpha therapy could potentially lead to functional cure in these patients. And the charm of this study is really the large data we have seen. So take-home points are the use of predictors for achieving functional cure in patients with chronic hepatitis B could identify which patients may benefit from PEG interferon alpha therapy, quite important, and treatment with PEG interferon alpha may be extended in those who do not achieve a functional cure by week 48 if tolerating treatment, but this needs to be seen in further data from this or other new studies. With that, we should switch now to hepatitis B plus Delta. Here, very interesting data was shown for bulevirtide. It was a large phase 3 trial using either bulevirtide at 2 milligrams or 10 milligrams versus delayed therapy, so no treatment in patients. They received the compound for 48 weeks, and you see here in the left panel the response rate for the two doses at week 24 and now also for week 48. And you see that the bulevirtide 2 milligrams and 10 milligrams had absolutely the same efficacy for the two doses, 2 and 10 milligrams. And it was, of course, substantially more significant than delayed treatment. So without treatment, we are not seeing any responses. Here you see the mean HDV RNA decline. So with 2 and 10 milligrams, we observed in this study roughly 2 to 2.5 log decay of HBV RNA. And if you take the response rate, which was defined here as undetectable HDV RNA or at least 2 log decay, the response rates were 76 and 72% respectively. And the undetectability of HDV RNA was 20 and 12%, which again was insignificant for the two drug doses. If you now look for the various subgroups, there was a response in all patients independent from age, gender, race, baseline ALT, baseline HDV RNA level, HBV deemed treatment, and the presence or absence of cirrhosis. There were no significant severe adverse events related to bulevirtide leading to discontinuation, and therefore the European Medical Agency made a very wise decision in giving provisional approval of bulevirtide at 2 milligrams for the treatment of patients with delta hepatitis. Take-home messages here: treatment with bulevirtide at the 2 doses investigated was effective in achieving biochemical and biologic response at week 48 in patients with a delta. Benefit was seen across all subgroups, no differences in efficacy, and now the long-term effect data need to be seen as we have to see data on the combination of bulevirtide with other compounds such as interferons or farnesyltransferase inhibitors, lonafanib, which is also in a phase 3 development. We have also a study with bulevirtide in patients specifically with liver cirrhosis. I want to touch on that only very briefly. Here, bulevirtide 2 milligrams was given to 18 patients with quite advanced disease, compensated cirrhosis, and already clinically significant portal hypertension. And the main message here is that even in these more advanced patients, the virologic response is very similar to patients with compensated disease, and the safety is also very good. Just focus here on the far right column. Here you see the response at week 48. ALT normalization seen in 4 out of 5 patients, 80%. The major decline is in the range of 3 logs HDV RNA. 80% of patients have a more than 2 log decline. Only very few non-responders, around about 10%. And the definition of combined response on viral load and ALT was seen in 2/3 of the patients. And most important, the drug was safe in these patients with more advanced liver disease. This is just summarized here again. This compound in patients with clinically significant portal hypertension was safe and effective. And as I already mentioned, bile acids increases. This is expected, and it is asymptomatic. The last 2 studies I would like to cover on this CCO presentation are on the retreatment of patients who failed a nuke therapy with chronic hepatitis C. Here we have data from the large European registry where patients who failed 2 or 3 direct antiviral agents were retreated with voxilavir, velpatasvir, and sofosbuvir, and the data were collected retrospectively, as were all the demographics, virologic parameters, clinical characteristics at baseline, during therapy, and the end of treatment. Overall, the sustained virologic response rate per protocol were above 90%. 94% of patients were cured with the retreatment of Voxwell-Sof. The SVR rates were equivalent whether or not the physician used ribavirin, and the response rates were also in the range of 95%, even in patients if the sequence analysis showed at least 3 or even more NS5A mutations. And in patients who already failed 2 DAA regimens, the retreatment response with Voxwell-Sof were also 95%. Interestingly, the differences were more related to clinical parameters. So patients with a previous HCC had slightly lower SVR rates. Patients with a liver transplant had lower SVR rates. Patients with cirrhosis had slightly lower SVR rates. And patients with a Child-Pugh B score had lower SVR rates than patients with a Child-Pugh A score. So overall, this was success. The SVR rate was not really related to the prior treatment regimen. It was also effective in rare HCV genotypes and chimera. And in the multivariate analysis, treatment failure was exclusively linked to patients who had a previous HCC and patients suffering from liver cirrhosis. Of course, these 2 parameters are also clinically related, but they came up individually in the multivariate analysis. So any virological parameter did not predict the chances of achieving SVR. So in summary here, Voxwell-Sof for 12 weeks was highly effective in patients with a previous failure to direct antiviral agents. The strongest predictors of the treatment failure were non-virologic, previous HCC, and cirrhosis, especially Child-Pugh B patients, and SVR was achieved despite the presence of resistant associated substitutions and or rare genotypes and Chimera. A last study is on clezaprevir, biprentosvir plus sofosbuvir as retreatment after DEA failure in patients with chronic hepatitis C, and this is an investigator-initiated open-label single-arm trial from New Zealand. Ribavirin, interestingly, while used still in Europe, was omitted in New Zealand due to poor tolerability. So the people living in New Zealand may be a little bit more sensitive to anemia and other side effects with ribavirin. Overall, 66 patients were treated with clezaprevir, biprentosvir plus the addition of sofosbuvir, and the endpoints were SVR12 and safety. 55 patients completed the treatment. In an intent to treat analysis, the SVR rate was 93%. On a per protocol analysis, almost 100%, 98% of patients actually achieved a sustained biologic response. And again, here in this regimen, the 4 treatment failure observed, 3 of the 4 were for non-biologic failures. All of those patients were active drug users, and it highlights the need for support in this population. And there was only 1 confirmed virologic failure, and this patient is currently retreated with PIP plus soft plus ribavirin, probably for longer than 12 weeks. I would suggest that here one should give this patient 16 or 24 weeks if he has failed or she has failed this regimen. So the take-home points from this study is that patient was confirmed NS5A resistant and previous DAA failure. The regimen clezaprevir, biprentosvir plus the addition of sofosbuvir for 16 weeks was safe and effective. Absence of ribavirin apparently did not affect the efficacy, and it's certainly worthwhile also to consider in the standard non-responders to a DAA regimen that this regimen perhaps only needs 12 weeks, but the study did not explore that, so this remains unclear. And as the previous study, it is clear that treatment failure is related to non-virologic features, and more infrastructure is needed for patients who are injecting drugs and need definitely support in this respect. With that, I like to switch back to Sarah for a Q&A session. Many thanks.
Wonderful. And thanks to you, Dr. Zeuzem, for that excellent presentation. We've had a number of questions come in from participants and encourage participants to continue to submit those questions. And we'll do our best to answer as many as we can in the time remaining. And so, Dr. Zeuzem, our first question comes to us from Bradley. So going back to the Everest Project in the Chinese patients where they utilized interferon, based on those data from that very large trial, would you or do you now treat your patients with TDF and interferon alpha?
So this is currently a strategy which is not really implemented on a large scale in Western countries. Indeed, in patients I have treated personally with nucleotide inhibitors, polymerase inhibitors for quite a while, and these patients are just not declining with their HBs antigen, or have declined but don't really get down to undetectable levels with the HBs antigen. I discuss with my patient the addition of pegylated interferon to hope for a loss of S antigen. And these data from China now support this policy, and I may be in the future a little bit more aggressive in approaching my patient which are on a nuke therapy for quite a while to attempt a better response by the addition with pegylated interferon.
Great, thank you. Our next question is regarding hepatitis delta, comes to us from Mahak, who asks, can bulevirtide be used alongside with nukes in Hep B and Hep delta co-infected patients?
Yes, the majority actually of patients in these studies were also on a nuke, but we all know that the nuke is not really affecting the HDV RNA levels, and that they only have an effect on HBV DNA, and that the usefulness, the efficacy of using a nucleotide in co-infection is very limited. Nevertheless, because a lot of physicians are just desperate and patients sometimes have detectable HBV DNA levels, many patients are on a nuke, and bulevirtide can easily be added to this regimen. And there are no drug-drug interactions, no safety issues, but everybody has to re-challenge the question whether the nuke treatment is really indicated.
Sure, that makes sense. And then another bulevirtide question comes to us from Bradley, who asks, should bulevirtide be used chronically for hepatitis delta suppression beyond 48 weeks?
Great question. The European Medical Agency, which granted provisional approval for bulevirtide, has a writing saying that you can continue bulevirtide therapy as long as clinical response is noted. So at least with a provisional approval here in Europe, we are using bulevirtide in patients who are responding even beyond week 48. But of course, we must consider whether there are any exit strategies, because bulevirtide has to be injected on a daily basis. And I wonder how long patients are going to tolerate this daily injection. On the other hand, if we look at our diabetic population, diabetes patients are injecting themselves for the rest of their life. So if the disease is significant enough, I think we can motivate patients as long as the treatment remains safe and tolerable. So the clear answer is yes, as long as you observe additional clinical efficacy, you can continue, but it will depend on the label, which the FDA, for example, is granting bulevirtide. And there needs to be attempts also for stopping the treatment and see whether treatment response can be maintained, especially in those patients where HBV RNA becomes undetectable during therapy.
Great. And thank you for those comments. They're spurring more questions about bulevirtide and hepatitis delta. So question comes to us from Sarah, who asks, shall we use nucleotides in bulevirtide prophylactically to prevent HBV flares with declining hepatitis delta RNA levels?
Yes, this is a topic which comes more from the hepatitis C field. I'm not aware that the use of bulevirtide is creating ALT flares. And if there would be flares, it's also not proven that this would then be related to an increase of HBV DNA. So I would cautiously say at the moment that I see no indication with the current available data on using a new prophylactically in patients to prevent flares. But I would continue to check for HBV DNA levels and, of course, the HDV RNA levels, which is a challenge in the United States because only one laboratory is offering this test so far. And if patients would become HBV DNA positive, I would consider adding a nuke, but only if really significant amounts of HBV DNA would be detectable.
Okay, wonderful. And I think that answered the next question, but I'll read it just in case there's things to add. So Catherine asks, if you stop bulevirtide, would you start TDF for their hepatitis B?
No, I would not start it straight away, but again, in the surveillance of the patients, I would not only check for ALT and HDV RNA levels, but also continue to check for HBV DNA levels. And we have seen in the hepatitis B trials that really the definition of treatment or retreatment must be cautiously made. But it is very untypical that the B is rising sharply. But of course, theoretically, it is possible if you would be able to eliminate the Delta virus, but you would not be able to affect the presence of the B virus. It could potentially increase the HBV replication because Delta is suppressing the B replication. And if you eliminate D selectively, it could potentially lead to a high replicative B hepatitis, which then would be required to be treated with a nuke. It's all depending on the surveilling of the testing, and the indication should be as in the standard guidelines for hepatitis B, and I would not use anything preemptively.
Sure, that makes sense. And I think we have time for one last question. This one in hepatitis C. Yusuf asks, do you think boxilaprovir is safe enough for patients with cirrhosis?
It's certainly safe enough in patients with a Child-Pugh A cirrhosis. It's not approved in Child-Pugh B. And the question refers to a patient who is, of course, the negative parameter, as we have shown, the patient with a Child-Pugh B cirrhosis, which has failed a first treatment with a direct antiviral agent. And here, the question is whether you are going to repeat the treatment just with an NS5A inhibitor, sofosbuvir, perhaps plus the addition of ribavirin, and just prolong therapy, or whether you would be willing to include a protease inhibitor, trying to get a new drug class on board. If you would do this, which I would only do in Child-Pugh B patients with 7 points, very, very careful surveillance is required. We know from old data using protease inhibitors that the drug levels are heavily increasing and can cause liver toxicity, drug-induced liver injury, and you would need to be prepared with any kind of increase of ALT levels to take the protease inhibitor out of your regimen. It's a really case-by-case decision, and in countries where these patients have good access to liver transplantation, you should also consider the chances of this patient to receive a new organ and then eliminate the virus after successful liver transplantation.
Thank you very much to Dr. Zeuzem, and thank you to our listeners for joining in. As a reminder, to view the full EASL 2022 conference coverage program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.